هنتكلم النهارده ان شاء الله التوك بتاعتي عن الكينبوكس ديزيز patient with ulnar neutral or positive variance what to do. اوكي عندنا الكيس ودي الكيس الوحيده اللي وي بريزنت patient ميل patient عنده pain و limitation of 2 years duration ودي الاكس راي بتاعته دي plain اكس راي. Do you have any suggestions what to do? Okay, Khalid.
The patient is having a positive ulnar variance, so radial shortening would not be an option. If we are going to make unloading surgery, we should think other ways other than the radial shortening, of course. Still, unloading procedure have some scope in this patient, but if the wrist motion is greatly affected, I think we are going to shift to limited carpal fusion like scaphocapitate or something like this. But if we are going to think about unloading procedure, we should think about distal unloading procedures like capitate shortening or fusion of the third metacarpal with the capitate.
Okay, Dr. Khalid, don't you like to ask any questions, do any investigations? You moved direct to the treatment.
Yes, yes. I was rushing a little bit, but of course, it's better. It's very important, firstly, to examine the patient to address the complaint. Sometimes there is maybe associated problems with the patient, like carpal tunnel. But the most important thing is to address the wrist motion, because if the wrist motion is greatly affected, I think unloading procedures only may not be. We may shift to surgeries, which part of it excision of the lunate to remove the offending problem and the source of pain.
Don't you like to do any other investigations?
MRI, of course.
For what?
To make sure that other carpal bones is okay, there is no EVN in the other carpal bones. If I am going to plan to make an fusion.
Standard MRI?
Yes, standard MRI.
Okay. Any other suggestions?
دكتور احمد بس انا دكتور احمد
اوكي
زي الفل. انا بس عاوز في حاجه هو بس الام ار اي هنا كمان مهم للديستال راديال النر جوينت. في شيبس كده موجوده في يعني لاترال للالنا، فدي برضو means what means ما اعرفش، بس الديستال راديال النر جوينت افكتد، شكله افكتد، في انستابيليتي فيه. نعم.
This more fragment?
Yes. ايوه يس.
Okay.
بس هي دي اللي انا بس احنا مش عاوزين يعني الوقت بتسدد 7 دقايق، خلي بالك يعني.
طيب.
If we analyze this X-ray, we have ulnar positive, ulnar apartment, and it looks like to me that it's a stage 3 Kienbock disease. So that is a problem,
Okay.
according to the data you present.
Okay.
Right?
We'll move a little bit forward.
Okay.
Okay. Because of the time limits. So we will do MRI, but the MRI should be a gadolinium enhanced MRI. So because of according to Schmidt classification, this type of classification for the viability of the lunate in the Kienbock disease, it depends solely in the gadolinium enhanced MRI. So the normal MRI will provide a very little information regarding the viability of this of the lunate. And according to Schmidt classification, we classify the lunate vascularity in Kienbock disease into 3 types. Type A is the partially affected vascularity. Type A is normal. Type B is partially affected. Type C is totally affected, is totally avascular. And this classification is very important. I will see later what's the importance of this classification. So what's next? Okay. For this type, it was type A, normal vascularity. What to do next? Surgery? What do you think? No. Before surgery, we evaluate the vascularity of the lunate. Then we must evaluate the osseous condition, the bone itself. This is very simple. This is the Lekman classification. All of us, we know that very well. It classifies the lunate into 4 types: type 1, type 2, and type 3A, 3B, and recently added 3C, which is had a coronal split of the lunate, and stage 4, which is panarthritis. And most recent added stage 0, which is the predisposing factors. It's called stage 0 now. And this is very important for the decision making later on. And what next? Before surgery, we are going to do some sort of unloading procedure for this patient. But before doing that, don't we need to do anything else? We need to do arthroscopy. Why? This is what's called the Bain or arthroscopic classification of Kienbock disease, and each patient of Kienbock disease should underwent pre-op arthroscopic evaluation, because there is mismatch between the X-ray appearance and the arthroscopic appearance. Sometimes it's stage 1 or stage 0, stage 1 Lickman, and stage maybe 2 or 3 arthroscopic. And arthroscopic classification, this was proposed by Greg Bain in 2006, I remember, and to divide the stage into stage 1, 2, 3, and 4. Stage 0, which has a full functioning articular surface, no non-functioning one. Stage 1 was non-functional articular surface. Stage 2 has 2 non-functional articular surface. Stage 2B has a sagittal coronal split. And stage 3 non-functioning surface. Stage 4 is panarthritis. Non-functioning surface is a surface which has arthritis or severe appearance or disappearance of the cartilage, shedding of the cartilage. Mild fibrillation or synovitis is not considered non-functioning. And this is very, very important for decision making. And this is the short video of arthroscopy of this patient. And it is stage 0, both the radiocarpal and the midcarpal joint. Okay, no problem. Okay, the arthroscopy was normal. It's stage 0, all functioning arterial surface. So what to do next? Cavitate shortening is a very good suggestion. Okay. Actually, in 2017, Lickman, who proposed the Lickman classification, he published a very, very important paper. It's called the 21st century algorithm for Kienbock disease. It's very important. He amalgamated both the viability score, the osseous Lickman score, and the arthroscopic score into one algorithm for the management of the Kienbock disease. He looked at the lunate and the rest. So the lunate is either intact, no problem, or partial compromised, or total compromised. So intact, we protect it by some type of unloading procedure. Partial compromised, we reconstruct the lunate. And a total compromised, then we should do some sort of salvage procedure for the lunate. For the rest, if the rest is intact or partial affected, I think, we do some sort of partial arthrodesis. If the rest is total affected or compromised, we do pan-arthrodesis of the rest. And this is the table shows amalgamation of all these 3 classification. And also, before moving to surgery, also we should ask a very important question about the patient age. This is very, very important, because the patient younger than 15 years old usually doing very well with non-surgical treatment, and also patient above 70 years old. Even if it looks very bad, maybe Lickman stage 4, but above 70 years, we don't need any kind of surgery. Most surgical therapy is very good. So the patient age is a very important key factor for decision making in these patients. Okay, and this is maybe to facilitate the understanding of this algorithm. And this is the cases, the green one, the cases that the lunate is intact. And in this case, we need only protection, some sort of unloading. And this yellow case represents, yellow area represents the case where the lunate is compromised and we need some sort of reconstruction. And this area represents the lunate is totally compromised and we need some sort of salvage procedure. So this is our patient. Sorry. He has bone 3A, cartilage 0, and viability A. So what option do we have? Should we do radial shortening? No. Why? What will happen? Ulnar abutment syndrome. So this is not a good option. Another option, it's a very good option. Okay. Another option is this radial decancellation, what's called the El-Ramendi procedure. It's a very simple procedure and very, very effective. The last one is the capitate shortening, and all of these plus minus revascularization. So if we are going to do radial shortening, we are not going in this case. How much shortening should we do?
Maximum 4 millimeters.
So, very good. 2 millimeter produce about 90% unloading. And maybe 3 millimeter adding a little bit, but beyond 4 millimeter, nonsense. So the idea is between 2 and 4 millimeters. Not more, not less. Site of osteotomy, proximal or distal.
معلش يا دكتور احمد.
Okay.
نخلص.
No difference. No difference. Okay? The site of the plate, volar or dorsal, no difference. It doesn't matter. This is the closing wedge osteotomy. And it also modified very recently by a very small and mini invasive kind. This is the L-Ramendi decompression, distal decompression, just remove the cancellous bone and pack it more proximal, and to produce very good results. And this is our technique of radial of capitate shortening. Okay, we just stomide and then fix using a plate or Herbert screw or sometimes K-wires. Okay. And this is the osteotomy before compression, and this is after compression. Fixation methods, different fixation method, it doesn't matter. Indications and contraindications we have already spoken about. So the take-home message: if the Kienbock disease is still debatable, we don't have a very successful procedure, please consider bone viability and cartilage in your decision. Thank you very much.